My name is Kara Hoy. I am a student at University of South Florida. I am going to be going over my case study presentation on COPD, chronic obstructive pulmonary disease. Today we're going to be diving into the patient CK, a 52-year-old female. CK presented to the clinic stating, "I've had a horrible cough with lots of mucus for weeks. I can't seem to catch my breath." She states the cough began 3 weeks ago, productive with green phlegm, and she's unable to clear it. She states that she had smoked 3 packs per day for the last 4 years and gave it up 1 week ago when she noticed it was the only thing that helped reduce the frequency of her cough. She noticed her cough got worse when she smokes, attempts to exercise, and when the weather is cold. She states her shortness of breath began 4 days ago and has been getting worse with each day. She decided to come into the clinic when she was too short of breath and tired to complete her daily stair climb up to her bedroom, even after giving up her cigarettes. Auscultation of her lungs reveals high-pitched wheezing bilaterally. Further, upon physical examination, she appears anxious, sitting in a tripod position with pursed lips. Her nails are clubbed with a bluish tint. She does have an increased anterior to posterior chest wall diameter. Upon taking vital signs on CK, she shows 82% SpO2 on room air, an elevated heart rate of 115 beats per minute, high-pitched wheezes bilaterally, and an elevated blood pressure of 139/95. After physical examination, we did diagnostics and lab values to determine what the diagnosis is for CK. We found that she has a FEV1/FVC ratio of 0.6 using spirometry post-bronchodilator use. This ratio is a gold standard for diagnosing and assessing severity of the disease of COPD. A ratio less than 0.7 or 70% after bronchodilator administration indicates the presence of persistent airflow limitation, which is a characteristic of COPD. Therefore, with CK having a FEV1/FVC ratio of 0.6, this shows that she has clinical manifestations of COPD. Her chest ray showed increased anterior to posterior diameter, hyperinflation, and flattening of the diaphragm. This demonstrates a change that's frequently showed with COPD. After the physical examination, along with diagnostics and laboratory results for CK, I was able to come up with possible differential diagnoses. The first priority is acute exacerbation of COPD. This is a differential diagnosis because of the symptoms that CK showed, such as a productive cough with the green phlegm, shortness of breath, wheezing, her low oxygen saturation, and clubbing of her fingernails, while she was sitting in the tripod position with pursed lips. Her history of smoking, along with the FEV1/FVC ratio and her chest x-ray, all come to a diagnosis of COPD for CK. The other possible differential diagnoses are asthma, because of the acute onset of wheezing for CK, her shortness of breath, and that her coughing was triggered by exercise in cold weather. Bronchitis is another differential diagnosis due to her history of smoking, chronic cough with productive phlegm, shortness of breath, and excessive mucus. Cystic fibrosis is also a differential diagnosis due to the clubbing of her fingernails and hypoxemia. Lastly, interstitial lung disease is another differential diagnosis due to the dyspnea and cough. Overall, I was able to come to a decision and say that the diagnosis for CK is acute exacerbation of COPD. Now that we are able to diagnose CK with COPD, let's talk more about the pathophysiology behind COPD. This is a chronic obstructive pulmonary disease that has 2 different causes. The main cause is an irritant such as smoking that causes an inflammatory response. With the inflammatory response, neutrophils and macrophages are recruited and release multiple inflammatory mediators. Oxidants and excess protease lead to the destruction of the air sacs. Proteases are enzymes involved in breaking down proteins as part of normal repair. Usually they're counteracted by alpha-1 antitrypsin. However, another cause of COPD is the deficiency of alpha-1 antitrypsin. These air sacs are destroyed And the protease-mediated destruction of elastin leads to a loss of elastic recoil and results in airway collapse during exhalation. Some other things that happen in this process is hypertrophy of goblet cells. This causes excess mucus and bronchial smooth muscle contraction. The excess mucus can obstruct your airway, narrowing it, and it also can cause mucus plugs. Both of these cause an obstruction in the airway and decrease airflow. Both the inflammatory response and obstruction of the airways cause a decrease in the forced expiratory volume, FEV1, and tissue destruction leads to airflow limitation and impaired gas exchange. Hyperinflation of the lungs is often seen on imaging studies and occurs due to air trapping from airway collapse during exhalation. The inability to fully exhale also causes elevations in carbon dioxide levels. As this disease progresses, impairment of gas exchange is often seen. The reduction in ventilation or increase in physiological dead space leads to CO2 retention, which is also called hypercapnia, and also results in acute hypoxia. Common diagnostic and lab tests that you should perform on a patient if you suspect that they have COPD are an ABG, arterial blood gas. You'd want to look for CO2 retention with COPD, and you would also get a level of alpha-1 antitrypsin. With this, you would be able to determine if the patient has a deficiency, which is a common cause of COPD. Other diagnostic studies are spirometry, FEV1/FVC ratio. This is the gold standard for diagnosing and assessing the severity of COPD. A chest x-ray and CT findings can also show the changes made in the body with COPD. Common clinical manifestations of COPD are below. We have dyspnea, wheezing. It can also be accompanied by chest tightness. Cough usually is productive. It does not always have to be productive. Pursed lip breathing and tripod position are very common with COPD. This helps open up the airway for patients, and the pursed lip breathing helps them get the rest of their air out when their airway is obstructed. Patients that often do pursed lip breathe have barrel chest appearance and central cyanosis when arterial oxygenation is low. So you would see digital clubbing, you can see blue lips, peripheral extremities such as the fingernails and toenails, and in bad cases such as when the patient develops right-sided heart failure, you can have lower extremity edema. COPD is an irreversible chronic inflammatory lung disease. It causes irreversible limitation of airflow and tissue destruction. Therefore, there's no cure. There's nothing that can halt or reverse the progression of the disease process. Therefore, our main goal is going to be to limit progression as long as treating the symptoms and avoiding irritants that can cause flare-ups of the disease and exacerbations. There's lots of non-pharmacological and pharmacological treatment. We're going to start with non-pharmacological treatment. The most important is smoking cessation. With smoking cessation being the number one cause of COPD, it's super important that patients stop smoking. They can go to their doctors and get different medications that help with the cessation as well. The next most important is pulmonary rehab. The goal is to improve patients' physical function through therapies such as exercise training, education, and behavioral changes. This is indicated for all stages of COPD, and studies show that patients who undertake regular physical activity have a lower risk of exacerbations, COPD hospitalization admissions, and all-cause mortality. Some other different non-pharmacological treatments we have are education on inhalers and how to use them, education on their medication compliance and importance of adhering to their treatment, regular physical activity as well as oxygen therapy. Next, we will go into pharmacological treatment. So all the treatment and management with pharmacology is individualized per patient along with their signs and symptoms. Everyone's severity is different per patient. So for pharmacological treatment of COPD, our most normal medications are bronchodilators and inhaled corticosteroids. Those branch down into a bunch of different subcategories. I'm going to go over them in just a little bit of brief detail. But next I will talk about the gold recommendation for initial pharmacological therapy. This chart helps you determine which therapy is first and which therapy is best for each person based on their individual signs and symptoms along with severity. So bronchodilators, we have beta agonists, antimuscarinics, methylxanes. The beta 2 agonist relax the smooth muscle of the airways. And then we have antimuscarinics, which prevent bronchoconstriction by blocking M3 muscarinic receptors in smooth muscle. So in here we have short-acting and long-acting. Short-acting are very rapid. They're as needed. Then you have long-acting. You also call that LABA, and those are just maintenance. The other subcategory was inhaled corticosteroids. Usually these are used in combination with long-acting antimuscarinic agents to reduce inflammation. It's more beneficial to use these two together than it is to use them separately. For severe cases, you're going to want to have your patient go to the hospital and manage them inpatient. Things that you can do is oxygen for a low SpO2. You also would do bronchodilators the same, and then intravenous corticosteroids. If the patient has a possible bacterial infection, that also is a known cause of COPD because of the inflammation, you'd want to get them on some antibiotics. This oxygenation, you can start from a nasocannula. You can go all the way up to a mechanical ventilator, just depending on the patient's severity and symptoms. This is the gold recommendation for initial pharmacological therapy. So you're going to start with your spirometrically confirmed diagnosis, going into assessing the airflow limitation, assess signs and symptoms, and then you have your severity rating. You can have any different group of medications. This chart is what doctors use to determine what they should initially start with for medications with patients. So COPD presents differently across the lifespan. This is a preventable disease. It's found mainly in middle-aged to older adults. This prevalence of COPD does increase along with age. It does develop after exposure to chronic irritants and develops over the years. So you're not going to really see a child develop COPD. They can have different respiratory conditions that look the same with similar clinical manifestations, but this is primarily found in middle-aged to older adults. In regards to prognosis, it is a prevalent case of mortality worldwide. It's irreversible. Your focus is just reducing symptoms at that point. Patients with other comorbidities have a poor prognosis, things such as congestive heart failure, pulmonary hypertension. The prognosis does vary according to each person. Each person has a different severity, different signs, different symptoms. Another very important thing with the prognosis of patient versus patient is with the compliance of treatments and medications. You'll have some patients that are very compliant. Even though they have a more severe case of COPD, their compliance helps them limit progression. Whereas you do have some patients who are not as severe but don't follow up with the treatment. So their disease progresses much faster and catches up to that more severe patient I was talking about. Physicians do use the BODE tool. This is a body mass index, airflow obstruction, dyspnea, and exercise capacity. This tool, you're going to predict COPD survival based off the risk for mortality. So you get up to 10 points as shown on the right in that little chart, based on a 6-minute walk distance, your FV1%, BMI, and your MMRC. Caring for patients with COPD involves understanding various cultural and socio-cultural factors that influence their health and treatment. Some key considerations we can go through are each patient has individual beliefs. There you have different cultural beliefs about health and illness. This can affect how the patient perceives COPD and also their willingness to engage in treatment. Some other barriers we see are the fact that socioeconomically disadvantaged individuals and those living at poverty or below poverty are at a higher risk of developing chronic obstructive pulmonary disease. They have a higher risk to environmental risk factors such as tobacco, along with less access to affordable health care. Those patients face barriers that impact their ability to treat their COPD effectively. They may not be able to afford visits, diagnostic tests, or even medications. In the end, incorporating these cultural and sociocultural factors into care plans can enhance patient engagement. It can also improve adherence to treatment and ultimately lead to better health outcomes for those with COPD. So while we have talked about these topics multiple times throughout the case study presentation, I'm kind of going to just go over these briskly just to drive the message home for everyone. First, I'm going to go over teaching and anticipatory guidance. So while teaching a patient with COPD, the most important things are risks for developing COPD. Without risks, they can't develop COPD. So we're going to teach them how to avoid COPD. If they get the disease, we're going to help them understand what COPD is, that it's an irreversible process, but their goal is to slow down the progression of the disease, manage their symptoms. We're going to do that with lifestyle modifications, including pharmacological and non-pharmacologic management. The most important is to avoid irritants, especially smoking cessation, since it is the top leading cause of COPD. We're going to teach the patients about pulmonary rehab expectations and things such as that. So our expected health outcomes. There is no cure for COPD, no way to stop it, no way to reverse progression. Our goals of treatment and health outcomes include limiting the progression and avoiding the triggers, like I just stated as well. These flare-ups and exacerbations are caused by a lot of factors such as infection, cold air, irritants such as smoke, anxiety, and non-adherence to medications. So we're expecting the patient to follow up on their medications, come to each test with new diagnostics, kind of keep up, avoid smoke, irritants, any drastic temperature changes, and to come get treatment if they suspect any infection. Here are my references listed for the entire case study presentation. Thank you.